You're listening to the Pharmacy Podcast Network.
No one has ever made an impact by standing on the sidelines, whimpering, complaining, or protesting without taking action. We make progress by implementing our ideas. Pharmacists must take action. This is PolitiTalkRx, the highly charged, sometimes controversial, political internet radio talk show dedicated to the profession of pharmacy. The policies that shape our healthcare system are complex, and pharmacists, pharmacy professionals, and industry stakeholders must have a seat at the table to participate in conversations, discussions, and debates, which lead to actions that drive change supporting the profession of pharmacy. This podcast is intended to shake up the status quo and promote change to promote the profession of pharmacy while advocating for better patient care delivered by pharmacists. PolitiTalkRx is part of the U.S. healthcare system's largest and most influential network of podcasts dedicated to our profession, the Pharmacy Podcast Network.
Today's Pharmacy Podcast, PolitiTalkRx, is brought to you by TheraWorks Relief. It's not just another leg cramp remedy. Unlike other muscle cramp remedies, TheraWorks Relief fast-absorbing foam has been scientifically proven to prevent muscle cramps with daily use. Plus, TheraWorks Relief topical formulation is locally acting, so it only affects the area where it is applied. Find more information and products at TheraWorksRelief.com. That's TheraWorks relief.com. Hi, Scott. I really do appreciate coming on the show today, like I said, and I just wanted to put a disclaimer out there for everybody. When you come on the show, you're speaking for yourself, your opinion, so I just want to hear you, Scott. Just tell me you're speaking for yourself. Tell the people out there so we know that there's no conflict here, and we want to get your opinions. Hello. Welcome back to our third show for the PolitiTalkRx on the Pharmacy Podcast Network. I am here with, I call him the man, he hates when I say that, but Scott Knoer from Cleveland Clinic. He is the Chief Pharmacy Officer at Cleveland Clinic, and he has given us the honor of his time today. Scott, thank you so much for joining us today on PolitiTalkRx.
Scott, thanks so much for having me.
Scott, let's talk a little bit about how we got connected. Basically,
this whole Scott thing can be confusing for our audience.
It is. I think I have more of the feminine voice, so I think everybody will be okay with that. But I think we should talk a little bit about how we met, because for everybody out there who doesn't know what LinkedIn is, if you're that guy, you should be a little bit ashamed of yourself. But LinkedIn, we were on LinkedIn, and I saw Scott posting about PBMs. And I was like, this is awesome, because somebody is out there trying to communicate the reality of what's going on out there, and not just complaining, not just talking about the benefits, but really educating. And I want to say Cleveland Clinic, if you don't know already about the global brand that Cleveland Clinic is amazing. And so for somebody in your statute to be able to disseminate that education and your views on it, I thought it was an amazing opportunity to reach out. And then I saw you in the Keys. So tell the listeners a little bit about the trip to the Keys, because I think we have a little bit of a different build when it comes to our pharmacy CEs down in the Keys. So tell us a little bit about the Keys, Scott.
Absolutely, Scott. Well, the Cleveland Clinic, we've got most of our footprints here in Northeast Ohio. We have our main campus, which is, 1,700 beds, has the highest case mix index in the country. But most of our presence here, we have 11. We keep buying hospitals, other hospitals within an hour, 2 hours of Cleveland. Also, we've got a presence in Florida. So we have the hospital in Weston, Florida. And if things go right with the FTC and all, we will be adding 4 more hospitals down in Florida January 1st. So with that presence, and then we've got the international presence as well. I've got a connection with Florida. Our pharmacy director, Bill, our former pharmacy director, who's now the COO at Cleveland Clinic Weston, Ozzy Delgado, are down there, and they asked, if I want to come down and speak at their conference in the Keys. I think the Southeast Florida Society of Health System Pharmacists by far has the coolest CE in the world. Not only do they have CE in the Keys, they also have CE at Sea. They do an annual cruise for CE. So I'm thinking when you're from cold, wintry Ohio, Florida is the place to go for CE.
Yeah, and we welcome everybody. So we want to just, put that out there that we definitely welcome you, and we would love to have you join us, especially in the policymaking and push in our profession. We definitely are an all-inclusive. So I appreciate that. I think you just got back from the Middle East. Was that your trip?
Dubai. Boy, so far, I don't know if I'm coming or going. Most recently, I was in Vegas for a visiting meeting, but I am going. I'm going back to Florida next week, and then I'm going to Abu Dhabi in the middle of November. We have internationally, we have an executive health clinic in Toronto, Ontario, Canada. We have a fantastic hospital in Abu Dhabi, UAE, that's been open, I think, about 2 years, and we're building one directly across the street from Buckingham Palace in London, England. That one's not going to be ready until the first quarter of 2021.
Well, since we have the same name, do you think they'll let me take your place on some of these trips? Because it sounds phenomenal.
Very possible. I assume your passport's up to date.
Absolutely. I want to jump into some of the things that you actually spoke about down in the Keys when I actually got to shake the hand and trade our cards there. You were discussing a lot about the advancements of Cleveland Clinic and basically the telecommunication, telepharmacy, and how the advancements there are helping you connect with patients and the consumer. And for me, my background in marketing and pharmacy, that mixture really makes me see the services from a consumer's point of view. And sometimes I look from the big picture down to the small focus. So could you just talk about the advancements there in the telecommunication, telepharmacy aspect?
Absolutely. And they're really, Scott, they're related to our focus on population health management. So, we've got limited resources, and how do we reach as many patients as we possibly can? And we're looking at doing that across the enterprise of Cleveland Clinic, but my job is to look at that for pharmacy in particular. So we've got a lot of different stuff going on at the Cleveland Clinic, and we've had a EICU, which isn't pharmacy. So our physicians monitor hospitals that are remote, in-state, out-of-state, from a central command bunker, and that's been going extremely well. There are monitors and video and all that in the rooms at the remote locations. So that's been going fantastic. And then we've actually partnered with American Well, but we branded that as Cleveland Clinic Express Care, and that's app-based technology on your smartphone where patients can dial up and have an appointment with a physician. So that's been going for quite a while, and now pharmacy is involved, and pharmacists will have consults with patients online through that app-based dial-up. Now, right now, not yet. A patient can't yet request a pharmacist through that application. They have to go through their physician and get a consult, but we are doing follow-up with patients. Our goal is to have that so patients can directly access their pharmacist. Now,
would that specific issue be related to policies or legislation, or how does that work?
Well, it's a lot of stuff to figure out, all of it, including billing and infrastructure and all that. And we wanted to get it going with physicians. Our pharmacists have all been trained. They're doing the consults, but getting it integrated into the app is sort of phase 2. So it's on the way, but you got to get started and then keep improving the process. Yeah, absolutely. And this is nothing new. There's been this technology for probably a decade. I'm making numbers up there, in multiple states. And I think Kansas was one of the first ones to really allow this. Of course, Kansas is a very rural state, and there aren't pharmacies everywhere. And I don't know the details of that. We do have some remote dispensing here, and I've got 20 pharmacies across the Cleveland Clinic. And one of the Well, it's not a problem. It's a good thing, but we have a self-insured health plan. So me, my kids, and my wife, and all the employees here, get our prescriptions filled through the Cleveland Clinic pharmacies. And what is causing a couple of our busiest pharmacies, which are here on the main campus, is that so many employees were getting their refills that we had a hard time getting patients who weren't employees. They had long wait lines and all. So we have some remote dispensing technology that we work with the Board of Pharmacy here, so that especially refills, folks can pick them up from these kiosks, which are very near our two busiest pharmacies, and you can get first doses there. I love it because they know to put it in. It's on the way to my parking space, my parking garage. They send me a text, tell me it's there. I can stick my credit card in for the copay, and there's the option to be educated. I don't generally need that, being a pharmacist, but so I think the technology is fantastic to help us reach patients. It's got to be used appropriately, so there's still contact. But you mentioned advocacy, and that's a huge thing, Scott. I know it's something you're passionate about, and I have been fortunate in that the clinic has supported my advocacy efforts, related to things like collaborative practice in Ohio, and even more so on advocacy for against drug price increases.
Right, and I know we actually wanted to discuss that a little bit more.
Yeah, the views here are mine. I think a lot of those align with most healthcare organizations. But frankly, Scott, the increase in drug prices, compared to inflation, it's unsustainable. Drug prices are going up. Brand name drug prices on an average of 10% a year, and that's since the Great Recession, the consumer price index has been hovering around 1%. It's kind of gone up over the last year, and inflation's starting to pick up, and interest rates are going up. But if you look at every 7 years at a 10% increase, a price doubles. And drug prices for brand name drugs between 2008 and I think 2017, around there, don't quote me on that, brand name drug prices tripled. I don't know about you, Scott, or your family and friends, but through the Great Recession, how many people's salaries tripled? Okay, not many. Maybe some people got their dream job and became a CEO and they used to work in the mailroom, but most people didn't, so that's what we're dealing with drug costs. So, before the last election, I was kind of excited because all the candidates were talking about drug prices, right? I mean, Bernie Sanders was, Hillary Clinton was, and Trump was. Once the current president got elected, didn't hear about it for a while, and I guess I was, and some of the proposals didn't seem like they were really going after things. If you would ask me this 2 weeks ago, I would have been relatively frustrated. However, in the last 2 weeks, some pretty significant things have happened. There was a bipartisan bill, now I believe Trump signed it into law, on eliminating gag clauses. The two biggest problems with drug price increases are pharmaceutical manufacturers charging more than is reasonable, I would say, or than is sustainable. And there's, the new drugs. We thought Sovaldi was expensive at $80,000, but that actually cured hepatitis. It was expensive, but now we've got CAR-T that's $450,000. Now it cures cancer, but how much of that can you afford? So the two organizations, I guess, industries are PBMs, and we are ground zero for PBM shenanigans for exposing that. There's been an expose in the Columbus Dispatch that really pointed out how much money PBMs actually keep through spread. And I know you're a pharmacist, and probably most of our listeners are, but spread is the difference between what the PBM collects for drugs and what they pay the pharmacies. Do you know how much money just for Ohio Medicaid in spread PBMs made in 2017, Scott? I don't know, you're probably not up on that number.
I am not actually on that number, but I think all of us would love to hear it.
$220 million. I'll repeat that, $220 million. That's money they took in, and they paid that much less to pharmacies. Now, we've had, I believe, something like 150 independent pharmacies close in the last 3 or 5 years in Ohio, partly because of this. And you don't get a pick. There are only three big. It's an oligopoly, three big PBMs that control the vast majority of the business. And as an independent pharmacist, you don't get a red line contract and send them back and forth to your lawyers. You either take it or you leave it, the contract. And if you leave it, you can't fill, prescriptions for a third of your patients. So back to that $220 million. That's just on spread in Ohio. So there's some bigger states, there's some smaller states, but take 220 million times 50, that's just Medicaid. Then there's all the private insurance plans and Medicare, and it's mind-boggling, the billions and billions of dollars that are siphoned off of the healthcare system, really for middlemen that provide, I would argue, very little value. The PBMs would argue with me. You have to have your prescription adjudicated. You hand them your prescription card. They run that through the switch, and but that isn't really worth much. So it's staggering. And then you got rebates, DIR fees. Okay, PBMs, after we dispense pharmacies products, especially specialty pharmaceuticals, I would use the word, it's not actually accurate, but they they claw back DIR fees for us, which are supposed to be quality measures. There's no connection to quality that a pharmacy can control. This year, we're on track to have $4 million. That's money after we get paid by the PBM that they take back from our pharmacies just here at the Cleveland Clinic. So it's really, really a big problem. So anyway, world peace and world hunger. We have drug inflation, expensive new products on the pharmaceutical manufacturer side. We have middlemen sucking the life out of the healthcare system on the PBM side. But there's federal legislation banning gag clauses. That's where you're the pharmacist. I come in, I say, hey, I need to fill this prescription. And you couldn't tell the patient that, hey, if you pay for that in cash, it costs $3. If you run it through on your insurance card, they're going to charge you $90. So there was a gag clause. You couldn't say that. So that federal law eliminated the gag clause. It won't solve drug price increases for PBMs, but it's one step in the right direction. And then just yesterday, Alex Azar, the Secretary of Health and Human Services, announced that they are going to require manufacturers to list the price of a course of therapy in direct-to-consumer advertising in commercials. So I think that's great. Now, personally, I would like to ban direct-to-consumer advertising. It causes overutilization that's not appropriate, and pharma will argue against that. They will say that it's a First Amendment right. Well, it's only been legal in the United States since 1999. There are only 2 countries in the world that allow DTC advertising, us and New Zealand, and guess what? Us and New Zealand use more brand name products per capita than other countries. So requiring the prices is great because there's a toenail fungus that's advertising, toenail fungus medication. I doubt patients know it costs $20,000 for a course of therapy. So I think, it's going to be very powerful. What I was concerned about is the administration would not have the actual full cost of therapy. A lot of times they're trying to say, and what I hear is that they want to reduce what a patient pays at the counter. And while that's important to the patient, what really costs is the total cost to society, the amount to, the insurance company, because that's paid for by employers, it's paid for by taxpayers through Medicaid. So anyway, 2 very positive things. The requiring DTC advertising on the pharma side, they're adamantly opposed to it, and the gag clauses. So if you would ask me 2 weeks ago, there's been nothing that's been done on the federal level. Now we've got something addressing PBMs and addressing something with pharma. Again, not going to solve the problem, but a baby step. I'll take it.
And that's the thing, too, is that a lot of people, they see these small steps and they're like, that's it. That's what you guys been fighting for. And it's the people from the outside of the bubble type of thing, because there are those volunteers, people on the ground, people that read bills, people that read the policies hand in hand and know that this is a big step in the right direction because at one, pharmacy's getting noticed, right? Like these issues are on the surface and they're not going away, and they run very deep. And I think what you said there is the insurer that's one of the things that we don't talk about ever as well is transparency of the insurer. What are the profits? What are the increases? And that's another piece of this puzzle. Let me ask you, in playing devil's advocate here, with the gag ruling, so I actually saw a pharmacist recently post and say, yeah, but how many pharmacists were actually feeling the barrier of not being able to say the cash price to their patient, and then also, I guess the idea is how many pharmacists are out there that actually would actively try to save each patient. And I think there's many out there, so that question could be kind of nulled. But the idea of how much does this actually create a positive step in regards to saving patients money. Was this a huge problem out there, or was it just something in the right direction? I just wanted to get your take on that. That was a question that I had on social media.
Great question, Scott. And it's a small step. You got to start somewhere. This does impact patients. Now, one of the problems is with this law, it says the pharmacist can tell them. It doesn't say they're required to tell them. I would always like to make things stronger. I'm sure it happens, on a fairly regular basis. Now, my guess, Scott, pharmacist to pharmacist, is that some pharmacists probably told patients anyway, because that's the kind of people that we are, trying to reduce costs. So this isn't going to solve world peace and world hunger, but it is a real issue that does impact patients, and it's a beginning. I'd say, Scott, in Florida, it's similar to your collaborative practice efforts. I've worked with our Cleveland Clinic pharmacy team down there, and Bill Kernan, give a shout out to Bill. He's the incoming president of Florida Society of Health System Pharmacists, the president-elect, and Kathy Baldwin, who is a fantastic patient advocate.
My pharmacy mother.
Yeah, right. Yeah, and but she's incredible. She's passionate, and she's a past president at FSHP, and she's agreed to stay on as they try to collaborate to get collaborative practice passed. In Ohio, I'll tell you from our experiences, we failed multiple years to improve it, and then we finally got it done. So, you guys you're making progress. You got further than you did last year. It's kind of like you got to start somewhere and don't give up. So, I think the gag clause thing, again, it's a baby step, but it's a step in the right direction.
Well, I think what you said there is you got to have something first, and it's kind of like that one step before the other. A lot of people, when they go into policy, they think that you need to go all in or not at all, and I've heard that many times. I've always said proof of concept, like we first started talking about. Let us prove to you that one thing can work so that we can get two. And I know that sometimes that we need some things expedited, but I think that if we can collectively understand that that's the process, that's what we're up against, let's all start to strategize how to make one step before the other. So going back to the...
Yeah, go ahead. Going back to farm. So obviously, we need pharmaceutical manufacturers. So I am not anti-pharma. I'm anti-egregious price increases. Without drugs, we couldn't cure patients. And there's been such amazing things that come out. Again, Sovaldi, who would have thought you could cure hepatitis, and these CAR T, well, it can be toxic and some patients don't tolerate it or live. For the patients does. I mean, it actually cures them. So it's incredible, but we just cannot, it's not just Scott saying that, it's unsustainable. We cannot have this percentage increase in pharmaceuticals year over year, or the whole system of healthcare will collapse.
Well, and we see that, especially where you're at too, the opioid, like the naloxone, Narcan, your antagonists, these things are put into policies in states, and a lot of it is very high priced. And, I guess I'm looking back many years to when drugs were catered to public health and there was royalties from the FDA and so forth like that. So, we see it in all areas that there's profits to be made. Now, you're absolutely right. We can't go around, and even in that subject, blaming all manufacturers and saying that big pharma is the evil, because a lot of the money that we're seeing is for research. It is for the networking to those clinicians, because that stuff is not cheap. And to get an old dog to do new tricks is not easy at all either. I'm glad to see more pharmacists becoming part of the the industry and being out there to educate, because I think that now we have a friend in the game there as well. But you're absolutely right, and I really do appreciate that. I wanted to go back a little bit to drug pricing real quick before we get off, and say what at your end, other than PBMs and addressing this, and other than what we've already discussed, what are your thoughts on the administration statement about charging other countries more and things like that?
Yeah, absolutely, Scott. And you know what? I mean, in my core, I'm kind of a free market guy, and but it's not working, right? So I mean, that's a problem. I would like for supply and demand to fix all the problems, but it hasn't functioned. It's broken. I'm sorry, what was the question, Scott?
Well, what would be your solution, other than the PBMs and what we've discussed, to lowering the drug prices? Sorry.
And the question was on other countries, right, related to that.
Yeah.
subsidize the whole world. So back now, I haven't researched this for a couple of years, but Sovaldi, when that came out, it was, I found the prices in different countries, and it varied dramatically, but it was $80,000 for a course of therapy here and $900 in Egypt. $900 versus $80,000. So you could go take the vacation and tour the pyramids, ride a camel, get your Sovaldi, and still save tens of thousands of dollars. Now, the United Kingdom...
sounds like a commercial.
Yeah, exactly, right? But the UK has decided... are you familiar with NICE? And boy, I should know right off the hand what that stands for, National Institute of something. But basically, they look at the cost effectiveness of therapy. So you have to say, what is, so like some of these new oncology medications, they may extend your life for 2 months, but they cost another $300,000. What is a quality adjusted life year worth? Because,
right.
If it's your kid or your mom, it's probably worth a lot, but how do you put a dollar on that societally? And I would say that in the UK, now don't quote me on this, but I believe they said a quality adjusted life year, so it extends your year with a quality life for a year, is worth £100,000. That number may not be exactly accurate. The point is they put a number on it, and they won't pay for new therapies that cost more than what they put a quality on. And I think that, and here we got ICER, again, an acronym. I can't remember the exact definition, but it's the same thing where they do cost comparative literature. And I think using ICER data would be very helpful. Now, I talk bad about PBMs. Now, again, I think PBMs have morphed into something that is non-transparent and really, really far exceeds their value, what they're taking out of the system. But they do some important things. And one of the things, I'm not going to mention any names of companies, but one of them recently said they were going to use ICER data and that they would not put drugs on formulary without ICER data. Now that, I think, is brilliant. I would love to see that move forward. In order to control costs, we're going to have to do that.
Well, I agree, and as much as it may not sound and sit well with people, and there's going to be a lot of going back and forth on that, I think it needs to be a variable in the discussion, and it hasn't been present. So I definitely appreciate that. Scott, I wanted to say I truly, truly, truly appreciate you coming on the show today. I truly appreciate you working with us. I look forward to our working relationship, our personal relationship. I look forward to seeing you back in the Keys, because that trip is always epic. But, you're doing so much for our profession, and it's just an honor to be able to have this opportunity to speak with you on PolitiTalkRx. So thank you so much, and thank you for coming on the show today.
And I guess I should go back to my disclaimer, because I say lots of stuff, but I do only speak officially for myself.
Absolutely.
I think I echo a lot of what other health systems and people are saying, but the words that were spoken here are Scott Knoer's views on the world and not anybody else's.
And that's where we hear them first, right here on PolitiTalkRx. We get to hear the discussions and the opinions and really freely talk, and that's what I love. So thank you so much. I really do appreciate it, Scott. I hope you have a great day, and I look forward to working with you in the near future.
Thank you, my friend.
All right, have a great day. Thank you.
Thank you for listening to PolitiTalkRx, part of the Pharmacy Podcast Network. If you're in the profession of pharmacy or if you're in the healthcare industry, you can't afford to sit idle and not be informed about your profession. We ask you to share these podcasts with your fellow pharmacy associates, your state and local government officials, and get involved in politics in some capacity, starting with being informed. We must take action, but only when we're educated and understand the issues and policies which lead us to a better tomorrow for our profession. Be sure to follow us on Twitter at PolitiTalkRx and send us an email at PolitiTalkRx@gmail.com.